right, welcome to this deep dive on managing chronic hyponatremia from SIAD in the outpatient setting. As clinicians, we see this all the time, right? So today, we're going to build a really clear, evidence-based playbook that you can actually use in your practice. So let's kick things off with a question that, honestly, I think we all wrestle with in the clinic. Is fluid restriction really enough? How do we know when it's just not working and it's time to step things up? Okay, so here's how we're going to tackle this. First, we'll look at the challenge itself, then a quick refresher on diagnosis. After that, we'll dive into first line, second line, and even some emerging therapies. And we'll wrap it all up with a practical playbook. Right, let's talk about why this matters so much. Chronic hyponatremia, it's just so much more than a number on a lab report, isn't it? I mean, this is a really significant clinical issue. We're talking about an increased risk of falls, bone fractures, and even cognitive problems that can seriously mess with a patient's quality of life. But, before we even think about treatment, we have to be rock solid on the diagnosis. So let's do a quick refresher on the essential criteria that we all need to have locked down. Okay, so these are the key pillars straight from the European guidelines. You know the drill, we're looking for that classic picture of hypotonicity, but with urine that's way more concentrated than it should be, all in a patient who looks euvolemic. And, this is the big one, SIADH is a diagnosis of exclusion. You have to make sure adrenal, thyroid, and pituitary functions are all normal. And it's so important to remember the huge range of things that can cause this. I mean, it could be anything from malignancies and CNS issues to really common drugs we prescribe all the time, SSRIs, anticonvulsants, you name it. Finding that root cause and dealing with it, that's a huge piece of the puzzle. All right, diagnosis is confirmed. Let's get into the treatment. Step 1, the cornerstone of how we start managing this is, of course, fluid restriction. This is standard practice, recommended in both the European and US guidelines. We're usually aiming for less than a liter a day, somewhere in that 500 to 1,000 milliliter range to try and get them into a negative water balance. But how well does it actually work? Well, the efficacy can be pretty modest. And this is really interesting. Look at the data from a key randomized trial. With fluid restriction, serum sodium went up by about 3 millimoles per liter. Without it, it still went up by 1 millimoles per liter. So yeah, it's a statistically significant difference, but in the real world, that's not a huge jump. And it gets even more stark when you look at bigger observational studies. Get this, up to half, 50% of patients just don't get a good enough response from fluid restriction alone. That's a huge number, and it's something we absolutely have to keep in mind in the clinic. So, that brings us to the big question, right? When do we call it? When do we say, okay, this isn't working, and decide it's time to move on to something else? Well, the good news is we can actually predict who's not going to respond pretty well right from the get-go. If your patient has a high urine osmolality or a high urine sodium, the odds are they won't do great with just fluid restriction. This is super helpful because it lets us anticipate who might need a second-line treatment much earlier. Okay, so that's our cue to escalate. Let's talk about our second-line options. When fluid restriction fails, we've basically got two main tools in the toolbox, urea and the vaptans. Let's put them head-to-head. First step, urea. A big systematic review showed it's pretty effective. We're talking an average increase in serum sodium of 4.6 millimoles per liter in about 5 days. So right away, you can see that's a much bigger punch than fluid restriction. So here's where the decision-making really comes in. It's all about picking the right tool for the right patient. On one side, you've got urea. It works by causing an osmotic diuresis, it's effective, and hey, it's cheap. The big problem? It tastes awful. I mean, that bitter taste is a huge reason patients just stop taking it. Then on the other side, you have tolvaptan. This is a more targeted approach. It's a V2 receptor antagonist that causes a pure water loss, or aquaresis. We know from the SALT trials that it works really well. But it's expensive, and you have to be super careful about correcting the sodium too quickly. That risk means you've got to monitor them closely, especially when you're just starting. All right, but what about those really tough cases? The patients who don't respond to our second-line therapies? Well, for them, we have to look at third-line options and what's coming down the pipeline. Now, this is fascinating because it really challenges something many of us were taught to do. The old combo of a loop diuretic plus salt tablets, right? It just makes sense. But a recent, really well-done randomized controlled trial found that adding it to fluid restriction didn't really provide any extra benefit. That's a big deal. It really makes you rethink whether this should be a go-to third-line strategy. And this is where things get really exciting, looking forward. SGLT2 inhibitors. They could be a total game changer. By making patients spill glucose in their urine, they create an osmotic diuresis, a totally new way to tackle SIAD. Now, it's still being investigated for this, but the early signs are really promising. This could definitely be where the future of treatment is headed. Okay, we've covered a lot of ground, so let's pull it all together into a simple, step-by-step playbook you can use in your clinic tomorrow. Step 1, nail the diagnosis. Use all the standard criteria, and please, please, please do not forget to rule out adrenal insufficiency. It can look exactly like SIAD, but the treatment is completely different. Getting a baseline cortisol is absolutely non-negotiable. Step 2, start with first-line therapy. That means fluid restriction less than a liter a day. But the key isn't just writing the order. It's about checking in, seeing how they're responding, and let's be honest, seeing if they can actually stick to it. Step 3, know when to move on. If that sodium isn't budging, or if you had a patient with those red flags at the start, like that high urine osmolality, it's time to call it. First-line therapy has failed, and we need to escalate. And that brings us to step 4, choosing your second-line agent. And look, this is where the art of medicine comes in. It's a real conversation. You have to weigh the cost and availability, think about if your patient can really tolerate urea, and balance all of that against the risks and monitoring that come with using a vaptan. There's no one-size-fits-all answer here. And that leaves us with a really interesting question to think about. With all these new therapies coming, like SGLT2 inhibitors, our toolkit is getting so much better. So you have to wonder, is that traditional pyramid of SIAD management with fluid restriction as the unshakable foundation about to be completely turned on its head in the next few years? It's definitely something to watch.